Okay, welcome all to MIDRC, Medical Imaging and Data Resource Center, and welcome to our first of many seminars in our seminar series. We will be hosting these monthly. Today, I am very happy to introduce two speakers who are coming from MIDRC CRP 10. Visit our website at midrc.org to find out what that means. Today, our two speakers are Isabelle Hu and Jordan Fuhrman from the University of Chicago. I will introduce both of them now. I am Mary Ellen Geiger. I am one of the PIs of MIDRC, and I'm always available. If you have any questions, please visit our website, put in questions, sign up for our newsletter and all. Our first speaker will be Isabelle Hu, who just graduated with her PhD in medical physics from the University of Chicago. She has worked on AI in improving diagnosis using breast MRI and various novel AI techniques, as well as then switching to COVID research when the pandemic hit. She is currently just started an AI residency at Facebook. Our second speaker is Jordan Fuhrman, who also will be graduating soon with his PhD in medical physics at University of Chicago. He is a senior graduate student working on AI in low-dose CT of the thorax, looking at emphysema as well as coronary artery disease. He's also looking at neural CT to see the role of deep learning there. And also when COVID hit, Jordan switched his research to include analysis of COVID. And both of these will be presenting their work on COVID, Isabelle with chest radiographs and Jordan with thoracic CTs. So we will hold questions to the end. If you have questions, please use the Q&A button. And also, once Isabelle finishes, Jordan will start, and then I will come back on after both of them have finished to moderate hopefully a very exciting discussion session. So, Isabelle, do you want to start off?
Okay. Let me share my screen. Are you guys seeing the slides?
Yes, we are.
Okay, awesome. Okay, thank you for that introduction. Today I'll be presenting our project on deep learning for COVID-19 diagnosis and prognosis on chest radiography. So in the past year and a half, the COVID-19 pandemic has profoundly impacted our lives. This disease is highly contagious and it can cause severe illnesses. And because of that, early diagnosis is very important, not only for providing patients with timely treatment, but also for helping with disease containment from a public health perspective. And also accurate prognosis is important as well, because we can adjust treatment for patients if necessary, and also predict the needs for certain medical resources and optimize the allocation of those resources. Which is helpful when the pandemic puts a lot of strain on the healthcare system and when resources are limited. The lab confirmation of the SARS-CoV-2 virus is performed with an RT-PCR test. Early on in the pandemic, early detection and containment of the infection was hindered by the need to develop and produce and disseminate the RT-PCR assays. While there have been successful efforts to increase the testing capacity, shortages of test kits and the long processing times still remain a problem in resource-limited settings, especially during surges of COVID cases. Moreover, the RT-PCR tests have moderate and variable sensitivity in clinical practice, so repeated testing is recommended, which reduces false negatives, but also increases the waiting time. And those are some of the reasons why imaging is valuable in this case, because imaging exams can provide clinically actionable results, either for establishing a diagnosis or for guiding patient management. And chest radiography, or CXR, is recommended for triaging at patient presentation and disease monitoring for COVID-19 because of its fast speed, low cost, wide availability, and portability. The images on the right of this slide show a few common findings on COVID-19 patients' chest radiographs, including bilateral lower lobe consolidations, ground glass opacities, and peripheral airspace opacities. However, some of these features presented in CXR images are not specific to COVID-19. They could also be due to other diseases, and presentation can be subtle in non-severe patients. So especially under the shortage of radiology expertise during a pandemic, precise image assessment for COVID-19 can be a challenging task. So we investigated deep learning methods to perform COVID-19 early diagnosis using CXR at patient presentation, and investigated the role of standard and soft tissue CXR images in this task. We also used deep learning to predict patients' potential needs for intensive care in the next few days. And we defined intensive care here as intubation or ICU admission. We have been curating a large database since the beginning of the pandemic by consecutively collecting CXR exams of patients who underwent COVID-19 RT-PCR testing at UChicago medicine sites. For the purpose of performing early diagnosis at patient presentation, we used a subset of the database that included the first CXR exam of each patient acquired within 2 days after their initial RT-PCR test for the SARS-CoV-2 virus. We only included exams that contained both standard and soft tissue images, either from dual energy exams or from portable exams where a synthetic soft tissue image was generated by post-processing technology. And for the intensive care prediction, we used a subset of CXR exams for COVID-19 positive patients acquired during the period when they were COVID positive, and before they received any intensive care, if they ever did. We wanted to also take advantage of the large public CXR data sets established prior to the pandemic in our training. So, but we had the concern that pooling them together with our COVID data set would introduce confounding variables that are not related to the underlying disease itself. So we designed a sequential transfer learning strategy where the model was fine-tuned a few times on increasingly more complex and specific tasks. So first, the model was pre-trained on natural images in ImageNet and fine-tuned on the NIH chest X-ray 14 dataset, which has labels for a broad spectrum of 14 pathologies. So in this phase, the model learned to find general abnormalities on CXR. Then the model is refined to detect evidence of pneumonia specifically by fine-tuning it on the RSNA pneumonia detection challenge dataset, which has a high pneumonia prevalence. And finally, the model was fine-tuned again and evaluated on our COVID-19 dataset. We used a DenseNet 121 architecture, which is one of the state-of-the-art CNN architectures and has shown success in related tasks in medical imaging applications. So in phase 1 and 2, the model was evaluated on the original held out test sets specified by the 2 public databases that we used. These figures show the classification performance that we achieved, which were similar to those in recent publications on these 2 datasets. And the COVID dataset in phase 3 had 9,860 adult patients CXR exams, 15 of them tested COVID positive. It was split into training, validation, and testing, stratified by COVID-19 status of these patients. And among the COVID positive patients, their CXR were acquired under different patient visit status. This is the distribution across outpatient, inpatient, ICU, and emergency department patient visit status of the COVID-19 positive patients. So in phase 3 on COVID-19 diagnosis task, we took a two-stage approach. First, we performed lung segmentation using a unit-based model to get a cropped image that only contained the lung region on CXR, which was then used in the classification step. We compared doing and not doing segmentation and cropping before classification. And we fine-tuned the model on both standard and soft tissue CXR separately, as well as the combination of the two merged in a feature fusion manner, where the two DenseNet 121 models were trained with shared weights and their latent features were concatenated prior to the classification layer. The unit we used for segmentation was augmented by adding residual blocks between the up and down sampling paths and replacing the regular convolution blocks with inception blocks. So we achieved, when using full standard CXR, we achieved an AUC of 0.74, and when using crop standard CXR, we achieved an AUC of 0.76, and the difference between the two AUCs was statistically significant. And we also used GradCam heat maps to visualize regions that were influential to the model's prediction. Here are two examples where the GradCam heat maps indicated that when the full images were used, areas outside the lung or even outside the patient body contributed to the model's prediction. But the influence from these irrelevant regions was reduced or eliminated by using the cropped images. And so we will discuss results on cropped images from now on. So we achieved AUC values of 0.76, 0.73, and 0.78 when using cropped standard CXR, cropped soft tissue CXR, and a combination of both. And soft tissue images failed to demonstrate significant additional benefit in terms of AUC. This could be due to the fact that most images in our datasets were from portable exams. So the synthetic soft tissue images have been shown clinically to be not as useful as the dual energy soft tissue images because they can have artifacts and the post-processing doesn't really provide new information, whereas taking another image with a different beam energy does provide additional information. And we also calculated other evaluation metrics at two sensitivity levels, 0.95 and 0.9, because the operating range that we were interested in is in the high sensitivity regime for diagnosing COVID-19 on CXR exams. And when we compared the specificities using MIDRC test at these two sensitivity levels, the specificity was significantly higher when using a fusion of both types of CSR than using the standard CXR alone. Here are some examples to illustrate the differences when standard image and soft tissue images were used. In both of these cases, one positive case and one negative case, using standard CXR images resulted in more accurate predictions, possibly due to the generation of synthetic soft tissue images. However, in these two examples, also a positive and a negative, they both show activations in the shoulder region on the standard images, which in the negative example led to a false positive prediction. Whereas in the soft tissue images, the bones were removed and the shoulder region was not influential to the model prediction. In both cases, the soft tissue model yielded a more accurate prediction. So the method we developed for COVID-19 diagnosis was translatable to prognosis tasks. So we predicted patients' needs for intensive care within the next 1 day, 2 days, 3 days, and 4 days from when the CXR exam was acquired. So to do that, we followed the learning curriculum in 3 phases and changed the final step to a multi-label classification to predict probabilities for 4 classes that we just mentioned. And on the independent test set, we achieved an AUC of 0.77 when predicting for intensive care needs 1 day in advance, and slightly lower but still reasonable performance for even earlier predictions, ranging from 0.73 to 0.74 for predictions 2 to 4 days in advance. And here are 2 example GradCam heat maps. The top patient was admitted to ICU within 4 hours following the image shown here. And the bottom patient never needed any intensive care. So to summarize our study, we curated a large imaging database of patients with confirmed COVID-19 status. We utilized pre-pandemic CXR data sets in a sequential transfer learning strategy. We trained a CNN model to distinguish COVID-19 positive and negative patients using their initial chest X-ray exams at patient presentation and achieved promising performance. We also investigated the role of soft tissue images in CXR exams in addition to the standard images in a task of automated COVID-19 diagnosis using deep learning. And we also achieved promising results in predicting the needs for intensive care on CXR exams of COVID positive patients. In future work, we will continue working on establishing multi-institutional databases that contain diverse population and different imaging acquisition protocols in machines in order to assess the model robustness and generalizability through independent external validation. I know that MIDRC has been establishing a multi-institutional database, and we will continue to contribute our data to the effort. And we can also investigate temporal analysis on a sequence of images to take advantage of patients' previous CXR exams instead of only using a scan at a single time point. We can also work on multi-scale models by leveraging multiple instance learning to analyze patches of CXR and combine it with full image analysis. And finally, we can work on multimodal algorithms that combine image analysis with other forms of data, such as demographics, vital signs, lab tests, and EHR records. And I'd like to acknowledge many people behind this research project, including my advisor, Mary Ellen Geiger, and my committee members and all the Geiger Lab members and collaborators that I've worked with on this project, and the Human Imaging Research Office at UChicago, as well as our various funding sources that enabled this research. So thank you all for attending, and I'm happy to take questions later in the Q&A session.
Thank you, Isabelle. And as Jordan gets ready, I just like to thank you for that fantastic talk, and note to folks, this was just a portion of her fantastic PhD work. And as Jordan gets ready, I want to note to folks that please put your questions. We have a few coming in already in the Q&A. And once Jordan is done speaking on COVID on thoracic CT, we'll have a lively discussion. Thank you. Go ahead, Jordan. Thank you.
Okay, can you see my slides?
Yes, we can. All set.
Okay, thank you, Dr. Geiger, for that introduction earlier. As she mentioned before, my name is Jordan Fuhrman, and I'm a PhD student here at the University of Chicago. And I'm also a member of MIDRC on CRP10, which is focused on explainability and interpretability of machine intelligence methods. But this work that I'm presenting today is actually something that I've done outside of my work with MIDRC, which is a paper I published several months ago called Cascaded Deep Transfer Learning on Thoracic CT in COVID-19 patients treated with steroids. So over the past year and a half, many clinicians have turned to the use of corticosteroids to treat those patients who experience very severe COVID-19 symptoms. For example, they've used dexamethasone and methylprednisolone, which have shown good performance for treatment. However, these corticosteroids often come with potentially severe adverse side effects, and so they should be used fairly sparingly. And it would be very useful to develop tools that would help us identify patients which may or may not benefit from the use of these corticosteroids. Fortunately, recent advances in deep learning technology have provided us with powerful predictive capabilities. And so with that, what our group has hypothesized is that through the use of quantitative CT and deep learning, we can inform COVID-19 patient management by predicting if a patient will require corticosteroids, in our case, methylprednisolone, during their course of treatment. And then we can also use this tool to augment clinical measurements for mid-treatment decision-making. So to motivate this a little bit further, we performed a Kaplan-Meier survivor analysis on our patient cohort, except for instead of actual survival, we substituted our primary variable to be the duration of hospitalization. So if you look at the x-axis here, this indicates the number of days after the patient was admitted to the hospital, and then the cutoff, or when the patient was, the fraction remaining in the hospital, is the y-axis. So when the patient was removed from the hospital, that was the deciding variable. We split our cohort into three populations. First, those patients who did not require corticosteroids during their course of treatment. Second, those patients who did receive steroids but were at a relatively lower risk according to the pneumonia severity index. And then those patients who did receive steroids and were at a relatively high risk according to the pneumonia severity index. So what we observed is kind of what we expected to see, that those patients who required steroids did experience longer hospitalizations. And I want to be clear that that's because they were experiencing more severe disease stages, not because they were being treated with steroids. So the reason that I show this is that this kind of tool that could help us identify which patients may or may not need steroids could also be used to sort of predict on average how long the patient may need to be in the hospital. This is particularly important for COVID-19, as we've seen several times during the pandemic, especially even recently, that hospital systems are extremely stressed for resources, including just space and hospital beds. And so a tool like this could help us, or could help hospitals prepare for the amount of space that they need and the resources that they need to treat patients. Okay, so with all of that in mind, we set out for this study to complete two different tasks. First was the pretreatment analysis step, where we were trying to predict, based on a CT scan that was acquired upon hospitalization, whether or not a patient would need steroid administrations during their course of treatment at any point. So for this study, we had 41 total cases. Each of them had one CT scan acquired upon hospitalization, so a total of 41 scans. 27 of those patients received steroids and 14 of them did not. And then for the second part of the study, we were interested in developing a tool that would be used during treatment to help a clinician make the decision to continue with steroid treatments if the patient was on steroids, or to wean them off steroids if that would be appropriate. And so for this case, we utilized all CT scans that were acquired longitudinally throughout the course of treatment for all of these 41 scans, or 41 patients, so it's a total of 221 scans. All of these were acquired near the beginning of the pandemic in February and March of last year, and they were notably all acquired on GE scanners, with the imaging and patient demographic information listed here. So the method that we elected to use for this study was what we called cascaded transfer learning. So for those of you that are unfamiliar with transfer learning, it's a fairly common technique in medical image analysis with artificial intelligence, where a model is trained to do or to perform a task in one imaging domain and then applied to a similar task in a new imaging domain. So for example, what's commonly done in medical imaging is that a model will be trained for natural image classification, so identifying whether or not an image has cats or dogs or trees or just everyday natural objects within the image. And then what we assume is that the parameters that are learned for that model will also be useful for the application of application in medical imaging. And so that's exactly what we've done here. So we took our COVID-19 data, which was 221 CT scans, as well as an additional data set from a prior study of 814 low-dose CT scans that were required for evaluation of emphysema. So what we did is we took a VGG19 architecture and first trained it on natural image classification on the ImageNet database. We then tuned this VGG19 model for classification of emphysema using this the low-dose CT set so that the model would, in a way, get used to seeing grayscale images and potentially learn useful features of the lungs that would be indicative of disease. We then performed what we called the Cascade feature extraction step, which was where we used the fine-tuned VGG19 architecture to extract information from the COVID-19 patient scans. So to give you an idea of how this actually works, we have these two figures here. On the left is the architecture that actually extracts information from the images, and here in the middle of the slide is the sort of overall workflow for a given case. So to walk you through this, we have an individual CT slice that's put into the VGG19 architecture shown here. And you can note that the fine-tuned, the layers that were fine-tuned are identified by this dotted box for the emphysema classification task for fine-tuning. So we extracted latent feature maps from the max pooling layers throughout the VGG19 architecture, and then mean pooled those feature maps to form a representative feature vector of a single CT slice. But obviously, we're not super concerned about what's happening in any single slice. What we're concerned about is what's happening in the whole case. And so what we did from that point is took the entire CT scan, all of the individual slices, and put them into this deep transfer learning feature extraction step, which is shown here on the left. So the output of this step is a representative feature vector for each slice. We then pooled all of the slice level features together to form a scan level representation, performed principal component analysis to reduce the feature dimension, and then trained support vector machines for our two tasks, the pre-treatment management recommendation and the during treatment longitudinal analysis. From there, we split our 41 cases into 80% for 80% of the cases for training and 20% for testing, and then trained two support vector machine classifiers for our two tasks. I'm going to be very explicit about what the ground truth was for these tasks. So first we have this pre-treatment analysis with the 41 scans. So that was the ground truth for that case was whether or not a patient received steroid administrations at any point during their course of treatment. Now for the during treatment analysis, the ground truth was slightly different. It was whether or not a patient received steroids at any point after a particular scan's acquisition. So for example, if a patient had three CT scans three CT scan acquisitions throughout their course of treatment, and they were also undergoing steroid administrations until sometime between their second and third scans, then the ground truth for that patient would be a positive designation for the first scan, positive for the second, and negative for the third. We evaluated the performance of our classifiers using ROC analysis, with the area under the ROC curve serving as our figure of merit, and also performed temporal analysis for the mid-treatment task. So for that pre-treatment task, we were able to achieve an area under the curve of 0.85, which in our opinion was fairly strong performance. And there are two reasons why we think that. So first off is that this is not a very straightforward task. For example, in detection tasks, the disease is either there or it's not. And it's generally the ground truth is very clear, or at least there's a very clear set standard. In this case, the ground truth was the decision by the clinician to treat with steroids or not, which is somewhat subjective compared to other tasks. And so that's why we were happy that we were able to get somewhat decent agreement with the clinician's decision to treat with steroids or not. Additionally, our model was trained entirely on imaging data, whereas the clinicians obviously could use non-imaging data in their decision as well, such as a patient's medical history or their demographic information or whatever else they needed. And so the fact that we were able to get close to their performance was very encouraging for this preliminary study. The second stage of this study was the during treatment analysis, where we took the SVM output prediction score and assessed it temporally through a least squares fit of the two different populations, those who received steroids and those who did not. So what we observed was kind of what we were hoping to see, which was that at early points of hospitalization, so near where the patient was first admitted to the hospital, the patients who received steroids were on average producing significantly higher prediction scores than those who did not receive steroids. Then as time went on and as the patients neared their subsequent discharge, those patients who received steroids the curve tended towards the curve of those who did not receive steroids. And this convergence indicates kind of what we expect, that we're reaching some baseline prediction where the patient should no longer be on steroids. So I want to be clear about how we feel that this could be used clinically. So let's say a patient is admitted to the hospital and has a CT scan acquisition that produces a score of 0.8 or 0.85, then it's very likely that that patient would at some point need to undergo steroid administrations for their treatment. And the hospital could then plan accordingly, both in terms of just having the resources available and for the duration of hospitalization that is likely to happen when those patients need steroids. And let's say some time has passed, the patient has undergone steroid treatments and then produces a CT scan that has a prediction score of around 0.4 or 0.45. Then what this would indicate is that the patient is likely nearing the end of their hospitalization duration, and should, if they're not already off of steroids, perhaps begin weaned off steroids and prepared for discharge. So I want to give you a few conclusions for this preliminary study, which was based on the RSC analysis results and the temporal trends produced through least squares fitting. We've demonstrated that there is potential for this cascaded transfer learning technique for both the pre-treatment and mid-treatment tasks that I discussed for evaluating COVID-19 patient CT scans. I do want to quickly touch on a few limitations of this study. First off, we had a relatively small sample size. Obviously, this was from much further back in the pandemic. And so we've been currently working to validate this study on a much larger data set. Additionally, on a similar note, all of the patients in our cohort reacted well to the steroid administrations. So there were no bad outcomes or no deaths in our cohort. So that's obviously something that we need to include to fully understand the generalizability of our model. And finally, as I mentioned, we only used imaging data in our model, and we could potentially get improved performance by including additional information, such as a patient's response to therapy between time points or other clinical factors. Finally, just a quick comment on how we are actually validating our study. We recently received some additional data consisting of 916 cases with a total of 1920 imaging exams from some collaborators in Wuhan who have been a fantastic pleasure to work with. And we also have, from this data set, a much more general set of images. So for example, we have scans here from 5 different scanner manufacturers listed here, whereas the preliminary data set only had scans from GE scanners. Additionally, this data set does have those patients with bad outcomes, as I mentioned before. And then finally, if we're able to achieve strong performance on both the preliminary data set and this new validation set, we're planning to utilize data from MIDRC as final validation. Thank you. I'll be happy to take questions in just a moment, I think, after Dr. Geiger has a couple of comments.
Thank you very much, Jordan. Another wonderful talk. I appreciate both Isabelle and Jordan helping MIDRC get the seminar series off to the start. I thought it was quite appropriate. One on chest radiographs and one on chest CT in moving AI along. I think there are questions both in the chat and the Q&A. So maybe if both Jordan and Isabelle can turn their cameras on and help with these questions. So if you go to and please feel welcome to add more questions as you go off. Note that someone asked if the chest x-rays and CT scans are publicly available. Please note that if you go to midric.org or if you go directly to data.midric.org, you'll see that we currently have ingested over 60,000 imaging exams. Many of those, just under 50,000, are undergoing curation, which includes making sure that they're correctly de-identified, that we have the correct clinical and demographic characteristics so that we can build the data elements according to the data dictionary on Gen 3, so you can search and build your cohorts. These particular data, University of Chicago has donated roughly now 3,000 patients through the ACR pipeline, which is about 15,000 imaging studies, and we'll be giving 3,000 more. So those will be available. Those are chest x-rays. The CT image scans you see here are not ours to donate. They belong to our collaborators in Wuhan, but we will talk with them about going through MIDRC. So if you're looking for publicly available, well-curated data, please go to the MIDRC website and to the Gen 3 data.midric.org site to search the data set. But now getting back to our speakers, we have one. I believe the first two under Q&A came up when you were speaking, Isabelle. Can you see them there? One is, thank you very much for your huge work. I didn't catch how you defined optimal cutoff to evaluate all the metrics excluding AUC. So I believe they're asking about how you did sensitivity and all.
Yeah, so because of the limitations in terms of determining like one single optimal cutoff, we chose two sensitivity levels that are very high because we thought that that would be the regime that we would be interested in, because of the huge harm of not detecting someone who's COVID positive, and also because the RT-PCR test has relatively moderate sensitivity. And so imaging exams are supposed to be complementary to that. So we were interested in high sensitivity levels, and that's how we chose the target sensitivity levels that were above 0.9.
Thank you. And then there's another one, nice work. Do we know how the results compare to the performance of radiologists?
Yeah, so currently there's limitations to directly comparing computational results to human readers' results because there have been various studies reporting human readers' performance on similar and relevant tasks, but the performances reported span across a very wide range because of their different evaluation methods or because of the different data sets that they use. So currently in this work, we have so far focused on computational methods, and in the future, hopefully we can compare computational methods with human reader studies and I guess human readers aided by computational algorithms as well.
Thank you, Isabelle. And a note to folks, the data.midric.org website has been added to the Q&A as well as to the chat for enabling you all to go there. I think next we have a question for Jordan. Thank you, Jordan, for your awesome presentation. Have I understood correctly that both evaluation and education has been performed on the imbalanced data set?
Yes, that's correct. It was all done on that initial data set. And we did control for, equal prevalence of the steroid and not steroid cases in the training and testing sets respectively. But yes, all of the evaluation and training was done with that smaller data set. And that's something we're looking at now is validation on the larger data set.
Yes, and we're all very aware about training and testing, but keep in mind this was done when the testing was done, it was not done on the cases that the training was conducted on, but more in it was not a consistency result, but trained on some, tested on the other, and then redoing that until you had all of them tested on. I think one is stuck with that when you have a small data set, but now that Jordan is about ready to really work with the larger data set. He'll be able to separate it, similar to Isabelle, who had a much bigger data set. Interesting, even with Isabelle's data set, we are now 3 times that size in the university data set. So always more data. Okay, so it seems like all 4 questions in the Q&A are there, but we have some questions in the chat. So if we go to those, I think these might have been for
I think we were for Isabelle.
Isabelle, right? Right, Isabelle. Can you see them, Isabelle? There's noise
Yeah,
in
I
the
can.
soft tissue image. I know Isabelle did further looking at the well, go ahead, Isabelle. You know about the soft tissues images, how there was 2 types.
Yeah, so for this question about noise present in the soft tissue images and whether that affected results. Yeah, I think that's definitely a possibility, and that like the same soft tissue images are used by human readers as well. So our goal is to see, like, given the current soft tissue images available, whether that can provide any additional benefits to standard images to the algorithm. And we did combine soft tissue images with standard images, like both within a model, to take advantage of maybe the advantages from both. And I believe the first question about classification thresholds I already addressed when answering a previous question. And the next question about fine tuning. Yeah, so we, in every phase, we loaded the pre-trained weights from the previous phase and fine-tuned the entire model end to end. We determined that through some preliminary experiments in terms of like how much of the model should be fine-tuned to achieve the optimal results. And in terms of why DenseNet, why not shallower models, we used DenseNets. One reason was because DenseNet was used to analyze chest radiographs in other tasks, chest radiographs in previous public data sets such as NIH Chest X-ray 14, as well as CheckSpurt and RSNA pneumonia detection challenge data set. And so by using DenseNet, we were able to reproduce these previous benchmarks on the public data sets before moving on to our like novel step for COVID-19 diagnosis and prognosis. And we did do experiments with various models of various architectures, and DenseNet did provide a very good performance compared to other smaller, shallower models as well. I believe that's all the questions I see in the chat.
Okay, those are any other questions out there? I guess you could put them in the chat or the Q&A. I hope everyone has enjoyed this. We have in MIDRC 12 CRPs, those are collaborative research projects, and many of them are involved in AI machine learning of COVID. We also have other ones. One is on virtual clinical trials. Another one is related to crowdsourcing for truthing, but probably 2/3 of them are on AI with various different eyes on the project. I think this was a very good way to kick off the seminar, because ultimately we want to continue providing data so that others can create AI algorithms and hopefully expedite this through regulatory testing and to get to the public for the good of all. I think what you've seen today is that we can build on what we've done with AI in other areas. Isabelle has spent many years working on AI of breast MRI, breast MRI, and Jordan has spent many years working on AI on low-dose CT of the thorax. So they came in quite prepared to tackle this. And now that data is becoming much larger, we will be able to do even more fine tuning and move to the next stage. I welcome you all to the website and to look at these collaborative research projects. I want to point out that Jordan and Isabelle are on CRP10. And I don't know, Jordan, if you want to make any comments on some of the additional work you're doing. You and Isabelle is in CRP10. Jordan recently led a paper that all of CRP10 worked on explainability and interpretability, which is really important. But what I've seen from the early days is sometimes some of these output maps works and points to where which agree with the outcome, and other times, as Isabelle shown, there in other places. And you have to be very aware of that. You know, you can develop something, but you always will have to go back to the data and to look at, you know, it gave a high number, but did it really make sense? So Jordan, I don't know if you want to say any words about that paper you just submitted on explainability and interpretability from all of CRP10.
Sure. Yeah, the focus of this paper is to basically review how we can use explainability and interpretability for tackling specifically COVID, and especially clinical translation of these AI models. It's currently under review, so hopefully that will be published soon, but yeah.
Okay, thank you, Jordan. And when it is published, these will be put on the website. We're constantly expanding the MIDRC website, where we will include this presentation as well as papers coming from MIDRC investigators. Are there any other questions? Let's see. Oh, very nice work and presentation from Brian Roman. Okay, good question. We like those kind. We have 10 minutes left, but I think many of us have other items to get back to. Thank you again, Isabelle. Thank you again, Jordan. We're very bright future for both of them. Thank you all for attending. Goodbye.